All right. Good morning. My name is Gill Ford. I'm the perfusion manager with here at HMH. If I cough during this presentation, I'm sorry, but my kids brought their germs home, so this is the result of that. So just a quick overview of what we're going to go over. We're going to just briefly discuss what cardiogenic shock, the types of MCS devices used to manage it, and what the role of those MCS devices are. So cardiogenic shock is hyperperfusion and hypoxia due to low cardiac output, resulting in hemodynamic instability. These are some of the causes of cardiogenic shock: obstructed blood flow, so coronary artery disease, which can also result in heart attack, myocardial infarction, which is one of the leading causes, myocarditis, endocarditis, arrhythmia, and so on. So the role of the MCS devices is to decrease the workload of the heart, improve end organ perfusion, stabilize the patient's hemodynamics, decrease ventilator and pressure support, and as a bridge. MCS devices are not meant to treat the underlying issue though, right? They're just there to support the patient while we figure out what the problem is and figure out how to correct it. So the intra-aortic balloon pump is the most commonly used assist device. Unlike the other devices that we'll review, this one is not a ventricular assist device. It is just this one just increases blood flow to the heart. So the overall role of this: increased coronary perfusion through increased diastolic augmentation. Cardiac output, it doesn't really directly affect cardiac output. It assists with that by increasing coronary perfusion and reducing afterload, which in case improves the heart's contractility. Decreases O2 consumption by decreasing the workload of the heart. As I said, this is the most frequently used device. The reason for that is because of the ease of insertion. So you can insert it bedside without any imaging into the femoral artery. Now, if you do go axillary, which of course is off-label use, but if you go axillary, you will require imaging. As far as positioning of the balloon, it should be placed in the descending aorta, the tip of the balloon between the second and third intercostal muscles, also below the left subclavian artery. Counterpulsation, everybody has the overall understanding of counterpulsation. The balloon inflates during diastole, increasing coronary perfusion, deflates during systole, that way the heart can properly eject. The decrease in afterload is a byproduct of the balloon's deflation. It causes sort of a little vacuum effect, which decreases that pressure. As far as the catheters, you have several different size catheters: 34, 40, and 50 cc catheters. Those catheters are chosen depending on the patient's size or their height. As far as device management with balloons, they're fairly straightforward and simple. The balloon will manage itself for the most part. If you use the auto operating mode, you have three different operating modes: auto, semi-auto, auto. Auto is what it says. It'll choose the best source, the trigger for the device to time itself. That's usually ECG or pressure. The user will be responsible for setting the inflation interval. That's just determining how often that the balloon is going to beat. So 1-to-1, meaning every beat the balloon's going to inflate, or every other beat. You'll usually decrease that ratio as you're trying to wean the patient from the support. Otherwise, bedside management, anticoagulation management. So you want to make sure that the patient is properly anticoagulated. You don't want clots to form around the catheter. You want to make sure you're checking the position of the catheter daily. Make sure that it hasn't migrated up, potentially blocking off your left subclavian artery and blood flow to the patient's arm. You want to make sure that the catheter hasn't been pulled back, in which case it could block blood flow to the patient's renal arteries, causing issues there. You also want to make sure that you're assessing the insertion site. That's probably one of the leading causes of us having to change out these catheters at the insertion site where the catheter is exiting. A lot of time that catheter gets bent there, and it's just like a wire hanger. You'll never be able to bend it back into that original position, and so that catheter is going to continue just to kink off on you, and usually the only fix for that is to take the patient back to the cath lab or wherever you inserted it and exchange that balloon out. Checking radial and femoral pulses just to make sure that we have an obstructed blood flow to the patient's lower limbs, as well as that left arm that we discussed. And then making sure that the patient is in the proper position, making sure that their head isn't elevated more than 30 degrees, which could also kink off that catheter internally. So complications: vascular, stroke, limb ischemia, thrombocytopenia, infection. As far as these, I would say limb ischemia is probably the one that we should be most concerned about. Obviously, we're inserting a catheter into the artery, in which case we could easily obstruct blood flow to the patient's lower limbs. And then these are some of your contraindications when it comes to using balloons: regurg, aneurysm, dissection, peripheral vascular disease. As far as peripheral vascular disease, there's an easy workaround. You go in with axillary cannulation. Axillary cannulation over the past few years has been more common with balloons, just because you can ambulate, walk your patient, try to maintain their strength as you build them up for a transplant or whatever the next steps in their recovery are. So surprising, even though the balloon is the most widely used device in regards to mechanical circulatory support, several trials have been done over the years, and those trials have shown that there has been no short-term or long-term benefit in regards to mortality when using a balloon. Even though we've seen that, the balloon is still the most widely used for a lot of the reasons that I mentioned before: ease of insertion, as well as allowing us to get that patient to assess and determine if we need a higher level of support for that patient. So the Impella, this would be a higher level of support from our balloon catheters. It comes in different variations: the CP, which provides support up to about 3.5 liters, the Impella 5.5. Those two are both LVADs. The RP Flex, which is a right side device. These are short-term devices. Impella catheters must be inserted using direct imaging in the cath lab or in the operating room. You're going to run into some huge problems if you try to free float this across the aortic valve. It's a short-term device, as I said, microaxial pump. These pumps run at significantly high RPMs, usually potentially 40,000 up to 60,000 RPMs. So when you stay on these devices for a long time, you'll notice that you'll probably start seeing blood trauma. So you might start seeing more hemolysis over time, or other complications associated with that. With the LVAD, the blood is pulled across the LV. The blood is pulled from the LV across the aortic valve into the aorta. The Impella CP is approved for less than 4 days, up to 4 days. The Impella 5.5 is approved up to 14 days. When you go beyond those limits, you're going to start having mechanical failures, so you're going to start losing the internal sensors that are built into them, no longer seeing the waveforms that you would normally see on your monitor, which I'll show you those waveforms in just a moment. In regards to the hemodynamic effects, so the Impella reduces LV and diastolic pressure and volume, as well as increases your MAP and cardiac output. The RP Flex, as you can see here, again, it's another short-term pump inserted through the right IJ. It's positioned in the IVC. The blood inlet is positioned in the IVC, the outlet in the PA. This one can give you up to 4.4 liters and can be used for up to 14 days. Of course, most institutions use these beyond that time period, in which case I was talking about the failures that occur over time when that happens. This is the smallest, and there's not a lot of right heart support devices on the market that you can use. So this was actually a great a device for Impella to come out with. So as far as device and patient management, it's very straightforward. You can see everything on your screen when you're managing these patients. You can see your waveforms. Your pressures, your flows. As far as nurse management bedside, you want to make sure that what you're really paying attention to as far as these devices and make sure that they're secured properly. It's not hard for these devices to get pulled back across the LV. When they do get pulled across the LV, you always run the risk of the leaflets getting sucked into the catheter and getting torn up. So making sure that the pump is secured is very important, as well as making sure that the external components are secured. When you turn these patients, when you turn or move these patients up in the ICU, if you're not managing the device, it's highly likely that you could crack one of the external components, meaning the purge cassette connections or those lower connections built into the catheter. So it's very, very important to make sure you're monitoring the device as you're moving the patient. And then, of course, anticoagulation management. It's once you have a clot built up in these devices, usually it results in us having to change out the device. There are some protocols in place for us to try to manage that, such as TPA and infusions and stuff like that, but that doesn't always work, so making sure that the patient is properly anticoagulated is very important. The purge fluid is what's trying to help prevent us from getting that blood into the motor and the mechanical components of the Impella catheter. The purge fluid is usually D5W or formerly D5W with heparin. We've kind of moved away from that, and now we use D5W with bicarb. The bicarb, being able to take the heparin out of the purge solution helps us better manage the patient's anticoagulation. So that way you're not trying to figure out how much heparin the patient's getting from the device as opposed to how much heparin you should give the patient directly. So contraindications, similar to any other ventricular assist or any other assist device, thrombus, mechanical aortic valve, because we have to cross over the valve with this, aortic stenosis, regurgitation, peripheral vascular disease with the CP, because you won't be able to float that catheter if those blood vessels are narrow, and then ASD and VSD. These are the complications: bleeding, hemolysis, stroke, pump migration, and vascular injury. So in regards to clinical data, actually looking at the Impella, it showed similar results when it came to mortality as the balloon pump. There was no significant improvement in 30-day mortality, but the Impella has been shown to provide more hemodynamic support than the IABP can, because it does directly influence your patient's cardiac or support your patient's cardiac output. So ECLS devices. ECLS devices are all built up of the same components. The only difference in regards to the details is just what the manufacturer's setup looks like. But all ECLS devices have cannulas, the tubes inserted into the patient's heart or femoral vessels to pull and drain and return blood to the patient. Tubing, which is that clear tubing up in the upper right corner, which is usually going to be some biocompatible tubing that connects all of the components of your circuit, connect your patient's cannulas to the centrifugal head. That tubing, like I said, is biocompatible, trying to reduce the inflammatory response that will occur when you pull the patient's blood out of their body and through an extracorporeal circuit. And then, of course, you'll have your console to drive the pump as well as a motor to spin that centrifugal head. So one of the very first percutaneous MCS devices that came out was the tandem heart. A lot of times that device is associated with the hardware when that's actually a cannulation strategy, and what that is was a femoral venous cannula that was inserted into the femoral vein, and then it was transitioned across your atrial septum into the LV to pull oxygenated blood through the pump and then recirculate it back into the patient's aorta. This was probably one of the most highly used devices. The problem with this approach was that not very many cardiologists and physicians are comfortable with positioning this type of cannula and going across and creating an ASD just to provide left ventricular support. So as of now, it's not as commonly used as it was in the past. But like I said, tandem heart, when we're talking about this device or this, we're talking about a cannulation strategy versus a device. ProTech Duo, used for RVAD support. So this is a dual lumen cannula that can provide temporary support. When I say dual lumen, that means it's one cannula that has two holes inside of it, one that pulls blood, one that returns blood back to the patient. Two sizes are always chosen based off of the patient's size and how much support that they're going to need. These ones are inserted with requiring direct imaging in the OR or in the cath lab. It can be done as bedside as well, as long as you can get fluoro bedside. And with this, blood is drained from the RA, delivered to the PA. Very minimally invasive approach for providing a patient with RV support. So ECMO. ECMO is our highest level of mechanical circulatory support. When we place a patient on ECMO, we are usually taking over the function of their heart and lungs, or just their lungs. Just depends on what the patient needs. There's two types of ECMO. There's VA ECMO and then there's VV ECMO. When we're talking about supporting a patient in cardiogenic shock, we're usually referring more to VA ECMO, cardiopulmonary support, versus VV, which would just be respiratory support. If we were to go bedside and assess a patient to figure out if they needed ECMO support, VA would be the first option that we would place a patient on. Then after we place that patient on VA ECMO, we would reassess. That would give us an opportunity to reassess the patient and see if we need to go back in and do a cannula revision and switch them over to VV. But VA ECMO support would always be your first line of defense when you're managing a patient undergoing cardiogenic shock bedside and coding. The way VA ECMO works is deoxygenated blood is drained from the venous system. It's propelled through an oxygenator, returned to the arterial. This is used, as I mentioned before, same as any other MCS device. This is just used as a bridge. It's not going to resolve the underlying complications or issues that the patient is having. So we treat that as accordingly. So percutaneous cannulation sites, we usually will cannulate a femoral artery, femoral vein, IJ or subclavian, whatever sites are most accessible at the time. That's going to usually be your femoral artery and femoral vein. The complications associated, two of the complications associated with peripheral cannulation is increased afterload. So if you already have a weakened heart, that's going to cause even more stress on the heart, in which case you may have LV distension, because now you have competing flows going against each other. In that case, we usually put it in an LV vent to help decompress the LV, help it from becoming over distended, or just like in reference to a rubber band, if we stretch out that heart too much, eventually those fibers are going to just snap and that heart's going to be unrecoverable. Central cannulation, right atrium ascending aorta. This requires a full sternotomy. This is usually what we'll do in the operating room when we're unable to wean from bypass. Ideally, we want to send the patient up to the operating room with a closed chest, but if we're anticipating only having to put this in to allow the patient, because they have a stunned myocardium and they just need temporary support to allow them to recover and revascularize, this would be the option in the operating room. So right here is just an image kind of giving you an idea of how the blood is removed from the patient and returned to the patient. You can see that first one pulled from the femoral artery, returned through the IJ. The other two, the next one would be from fem-fem cannulation, and that third one would be using a dual lumen cannula, which pulls blood from the same cannula and returns it through that cannula as well. So when you're working on patients on ECMO or MCS devices, the most important thing is to make sure that you're actually managing the patient, not so much the device. A lot of times when these patients are having complications, it's not because of a mechanical failure, it's because of changes with the patient's hemodynamics. So you want to make sure that you're monitoring their lactate levels, inotropic support, vasodilators if needed, and making sure that we're maintaining therapeutic anticoagulation. That's very important on patients with ECMO versus standard MCS devices, because when you add that oxygenator in, you're adding a lot more resistance into your circuit, in which case it slows down your blood flow and can lead to more clot formation. You also want to make sure that you are monitoring all of your connections on ECMO. A lot of times, I know here at HMH we have ECMO specialists, but if you're the nurse managing this patient bedside, you also want to make sure you are aware of what all the connections and everything are on your circuit, making sure that all stopcocks and everything are connected properly. It takes less than a stopcock or something falling out on the arterial side. It would take you less than 5 seconds to fully exsanguinate a patient if you weren't paying attention or clamping out that circuit. Same thing on the venous side. If you had something come loose, a stopcock or whatever, it would take you less than a second to fully deprime that circuit and potentially pump air into your patient. So you really have to be diligent when you're monitoring these patients and making sure that everything is set up and connected properly. Case in point, patient on CRRT, most CRRT machines are able to, when they detect air, will clamp themselves off. This patient was on CRRT through the ECMO circuit on the venous line. Air was detected in the CRRT machine. It clamped itself off. Before it clamped itself off, it had pulled gross amounts of air all through the ECMO circuit. But patient did well. Fortunately, it just prompted us to wean them off ECMO earlier. Here are the same complications with all of the MCS devices. Hemolysis, limb ischemia, stroke, perforation, tamponade, cerebral vascular accidents, embolic complications, cannula malposition, infection, dissection, bleeding, and vascular injury. That applies to all devices across the board. What I didn't mention on there is, of course, is probably the inflammatory response, which is going to happen on all of these devices. Whenever you pull patient blood through any extracorporeal circuit, you're going to have contact activation as well as platelet activation. Platelet activation and your coagulation factors are going to be coagulated. So making sure that we are monitoring their blood gases and all of the ABGs is very important when managing these patients as well. And then this is just a summary page that goes over how some of the devices support, what support they provide, what support they don't provide. And that really sums up our discussion. You guys have any questions? Go ahead.
I have one simple question. My question is the balloons that you guys use for your heart, but you said they're still technically off-label for axillary insertion. I know that that's been doing that for...
My head is plugged up. Can you speak a little louder?
Why is the axillary balloon still considered off-label when Methodist has been using that
Because
for like 10 years now?
Because the manufacturers have to submit for FDA approval in order to change that. They're only approved for femoral insertion. There's no balloon on the market that is approved for axillary or subclavian insertion. So that just comes down to paperwork with the FDA. Go ahead. Absolutely not, because I don't know how to go back. Hold on. Let me see. Well, I would phone Tyree, but I don't know what he's doing, so I'm sure we can get that to you, though.
Question over here.
Yeah. Yes.
My question is basically, I know you were talking about those valves and stuff with the balloon pump. Why is it that we're just not going straight to the impella instead of using the balloon? I know you said it's just easier access and everything, but most times, you see a lot of failures for the balloon pumps.
Not some. I wouldn't say so much failures, but I think each device. Right. Right. So each device. So there's a role for each device. there's a role for each device. And so when you're talking about a balloon pump, it still has a role as far as providing temporary support. As far as balloon ruptures, that's not a mechanical defect with it. That's because that balloon catheter is usually rubbing against some sort of abrasive material, so maybe there's plaque in the aorta or something in regards to that. And that could also be in relation to how that catheter was handled prior to the insertion. So balloon ruptures, I wouldn't associate that with just being a overall mechanical failure. As far as, what was your other question about something failing on it?
Basically, you already mentioned the trials and everything.
Yeah.
Obviously, the impel is going to be better hemodynamic support.
Mhm.
Why are we just not jumping to that to optimize the patient the best we can?
Well, you also have to,
And then eventually, hey, you have to get an impel today.
well, all balloon patients don't transition over to an Impella catheter, but if I can put in this balloon pump and I can stabilize you in the ICU and you don't need a higher level of support, why wouldn't I start there versus taking you to the cath lab, where then I have to induce you, and all of these other complications that may be associated with the procedure in the cath lab. I would just say that's also physician preference as well. Do they want to go with an Impella? Do they want to go with a balloon pump? Any other questions? All right. Thank you.